welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, sending this message to you from Sydney, Australia. Normally I like to put my episodes out on the weekend, but I spent my weekend in the air flying to Sydney to teach a course about the lumbo-pelvic hip complex and the lower extremity issues of those areas of the body. And so I thought I would do something somewhat relevant to that topic, a little bit of a thought experiment about the TFL and low back pain. On the plane over, I was thinking a lot about how I could do better to teach the way the body responds to pain and overuse, injury, and aging. And as I probably said before, I consider aging to be a form of overuse injury. It's really just how much mileage we're putting on our body and how it responds to that. And the most common ways that it responds to that is muscle shortening. If you know the Yanda cross patterns, you know that tonic muscles are prone to shortening. Our postural muscles are in constant use. They're like a low level of use throughout the day, and those muscles will respond by shortening over time, leading to those cross patterns. So I wanted to just do a little bit of a thought experiment about how I look at assessment and treatment. As you may have heard me say before, I feel like if you're using muscle testing in order to know what to treat, you're not yet at a good level for helping the tough cases. Because in order to help the tough cases, you can't just muscle test. You have to know how the body responds to pain and injury. Or you're just not going to know where to look when you're stumped. So in order to do a better job at that, I just want to start delving a little bit more into how I look at assessment so that I can help the people that, for instance, I maybe can't do muscle testing on. If you treat a lot of seniors, I treat a lot of seniors, and sometimes they can barely get on the table. They're extremely obese, they're weak, they're in excruciating pain. Just being older makes them less mobile. So if you're going to treat somebody in their 70s and 80s, don't count on being able to do a lot of muscle testing to figure out what's going on. You have to actually know what the problem is in advance, and some of that you've got to gather just by questions. You've just got to be able to ask them, like, when does it hurt? Where does it hurt? Can you point to where it hurts? What makes it better? What makes it worse? What movements are you unable to do? What's your history of injury? Do you get numbness or tingling? Do you have any other symptoms that you can think of related to their problem so that you can figure it out without having to do muscle testing? And I really feel like that's essential for us to be able to assess without a lot of muscle testing for those reasons. The other thing is if you're treating athletes, you're treating professional athletes, you're treating bodybuilders, your muscle testing will not necessarily reveal a problem because they're strong and they're probably stronger than you are. So you could test something that's dysfunctional and they would still be strong or at least stronger than you are. And that's not going to lead you to understand the problem. You have to actually know how the body fails and know when you need to treat synergists that are not testing weak, but that can cause a postural dysfunction. They can cause a postural issue that leads to dysfunction. For instance, hip flexors are prone to getting short. So if you're muscle testing, just because something is testing strong doesn't mean it's not short, especially for someone who's a pro athlete. For instance, like the psoas could be short, and it probably is short. Anybody who's having inhibition of glute max, very likely a lot of that inhibition is caused by shortening of the hip flexors. So when you're trying to help somebody to get their glutes firing better, not only would you be using electric stim on the glutes, but you should be considering the hip flexors that are inhibiting the glute max. And you may not test weak on rectus femoris or perhaps psoas or TFL, but you should still be treating those synergists as a hip flexor group because you're going to improve their posture, which will help to not reciprocally inhibit the glutes. So I wanted to go through this thought experiment, and something I always noticed in Facebook groups for orthopedic acupuncture is somebody posts a tough case and they'll give the symptoms and they'll talk about maybe whatever they tried already, what failed, and they need some advice. And sometimes the people that I think they're counting on to give them that advice are telling them, "Oh, you didn't test enough. You didn't test enough of the muscles. So go back and test the muscles, and then come back to me." And sometimes those people are new. They're really new to orthopedics. They don't know all the muscle tests, and again, like muscle testing isn't necessarily going to reveal the problem, especially if they're treating somebody who's very strong. So they would be left with basically no help. And a lot of times I would put something in the comment section to say, test this, check this one muscle, like test this one muscle, like coracobrachialis. Stop fretting about all of the underlying instabilities of the scapulostabilizers. Get the person out of pain. Then you can worry about all of that stuff. It would, to me, it felt a bit frustrating that I felt like, these people, especially who are new, who have patients, real people who are in pain, and this is their only hope, probably. And we're telling them to go back and, fully assess the shoulder girdle before I can give you an answer. No, I really don't feel like that we should have to do that. For instance, if it is anterior shoulder pain, there are certain things that are going to cause anterior shoulder pain in a huge percentage of people. And if that person went through all of this functional testing and they come back and they say, I don't know what I'm missing. Well, if you didn't say anything in your post about coracobrachialis and they have anterior shoulder pain, I'm going to say that's like 80% of the time, that's like a huge reason for anterior shoulder pain. One, maybe you didn't need to even do a muscle test for it. Push on it. If it hurts, it's probably the cause of anterior shoulder pain. And I feel completely fine in the comment section telling them, check the coracobrachialis. It's it's very likely the problem. And then, I would see all the people they don't want to get anybody ripping on them for, not being thorough enough and exact enough and mentioning possible cervical compression or the underlying serratus anterior weakness, or perhaps the infraspinatus tendon is causing anterior shoulder pain, blah, 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 blah. If the person has already, done muscle testing and they're lost, this is what I'm going to tell you, anterior shoulder pain, look at coracobrachialis. So And I really think, a lot of times we we should understand more how the body fails, and then you can muscle test if you really need to show the patient, what you're thinking. But I'm very transparent with my thinking on patients. I'll say, my initial assessment is X, Y, and Z. This is what I think is going on. If that turns out to not be what I'm thinking, then I think we need to look at X, Y, and Z for this reason. But I want you to know upfront what I think is going on. And if you're feeling better from it, then this is the course of action we'll take. And if you're not feeling better, then I will adjust my treatment according to what you tell me is still going on, and we'll go from there. And I feel like this builds a lot of trust with the patient because you've been transparent, that you don't claim to know everything, and you also are letting them know that there are logical reasons why you're going to do what you're doing, and you're explaining the logic. And then if it isn't helpful, then you're also explaining that logic. And a lot of times what I'll tell people is, if you're feeling better from the treatment, but there's still something that's not quite right, there may be some restriction in the muscle that's called a trigger point. You may have some muscle shortening that's just not releasing, and then we'll have to address that separately with a different technique where I'm going to get that muscle to twitch without any electric stim, and that will release the fibers, and that could take a couple sessions to get it, really well released. But I want you to know up front, very likely you're going to feel much better from today's treatment. And when I see you next, we'll make adjustments accordingly. Also, know that if I'm releasing muscles that have been short and tight for a long time, and once they're released, you actually may have better mobility and then be able to feel something else that's tight and short that's causing you some pain. So because this is a chronic issue, this is a process. And I want you to know up front that, what I'm going to treat today is based on what you're presenting with, and based on how you improve, you may find something else in a different area that you can't feel right now. Um, and that's really how I like to talk to my patients and explain things. And I don't just, want them to lie on the table and just, muscle test everything and then treat what's weak. Because you can have a lot of weak muscles that aren't contributing to the pain as well. But let's do my little thought experiment. This is going to be about how the TFL can cause low back pain. So the first thing that I would want to talk about would be Yanda's lower cross, right? The hip flexors putting an anterior pelvic tilt that will inhibit the glutes, cause the low back muscles to have to overwork. And of course, as we've talked about before, those the spinal erector aponeurosis that comes down into the sacrum is attempting to stabilize the SI joint. The glute max is supposed to be primary stabilizer. Glute max medius come into that sacrotuberous ligament to stabilize the SI joint. When the glute max is failing, then the piriformis and deep rotators will shorten and tighten because they're trying to stabilize. The hamstrings will tighten because they're trying to stabilize the SI joint via the sacrotuberous ligament. But it completely fits into the Yanda pattern of lower cross. The abs become weak, the glute max becomes weak, the hip flexors get tight, the spinal erectors get tight. Puts a person into an anterior pelvic tilt. It puts more strain on the low lumbar area, and because of that stabilization issue, you will have spinal erectors and QL start to get super tight. I would say also you could add that the glute medius is prone to getting tight with trigger points when the glute max is not firing as well. But we're talking about the TFL. So the TFL, which is an internal rotator and a hip flexor and a hip abductor pelvic stabilizer, can become tight and usually does become tight on most people. So one of the things that can cause low back pain from a tight TFL, besides the anterior pelvic tilt that I just talked about, would be its role in lateral stabilization. So pelvic stabilization is when this pelvis is being held in alignment with the horizon while on one leg. When you walk, you're often not on a single leg. However, there is some pelvic stabilization involved. Running is a case where you're landing on one leg only at a time. You have the float phase and you're landing on one leg. So you see a lot of dysfunction of the TFL in runners, but it's helping to stabilize the pelvis for all of us, even just shifting weight left and right. Maybe just standing in line at the grocery store, shifting your weight. You are using those pelvic stabilizers, the glute medius, the gluteus minimus, and the TFL. Those muscles are helping to stabilize the hip. And contralateral to that, the QL on the opposite side is going to help keep the pelvis stabilized, especially when the pelvic stabilization is weak on the abductors. So you've got a tight TFL. Why does the TFL get tight from a lateral stabilization perspective? You've got the gluteus medius that is supposed to help stabilize the pelvis. You know the Trendelenburg test. If not, please Google it. I'm not going to explain it right now, but because that Trendelenburg effect is that the pelvic stabilization is weak, so you have a little bit of a drooping hip on the opposite side. The QL can engage to lift the hip back up because what does the QL do? It's a lateral flexor. It's a spinal erector. I mean, extensor. It can extend the lumbar and it can hike the hip. So if you're standing and you want to lift your left hip without you want to hike your left hip and lift your foot off the ground without bending your knee, your QL is going to do that. It's going to lift the pelvis up. So it has a function in pelvic stabilization, and it tends to overwork when the abductors and are dysfunctional on the opposite side. So when your glute med is weak, your TFL and your glute minimus have become tight because they're overworking to stabilize the pelvis. Then the contralateral QL can get tight because it has to work harder to keep your pelvis in alignment. And that's essential because otherwise we're tripping, right? We've got to keep our pelvis in alignment so that contralateral QL can get overworked, overused, and sore, achy. And it can eventually have trigger points that are going to cause a lot of pain. So on this one instance, so we've got the lower cross anterior pelvic tilt from a tight TFL, right? That puts more strain on the low back. It inhibits the glutes, causing more work for the low back and the hamstrings. And then you've got the lateral stabilization possibility, where the TFL has become tight, and now the contralateral QL has to work to lift the pelvis, and that can cause a QL issue. And it's something to always consider if you have a patient where you've resolved their QL tension and they're feeling better, but when they come back in, this one side keeps getting tight. And really good to check if that contralateral hip abduction is weakening for some reason, probably trigger points, because if it's coming back regularly, there's some dysfunction in there, probably some sort of muscle fiber dysfunction, tight bands and trigger points. Okay, and then what other things could the TFL do that would cause low back pain? Well, if you have somebody who has some SI joint pain that's being caused by piriformis being too tight, or possibly piriformis and the gemellus and obturator internus muscles all being short and tight because they are trying to stabilize the SI joint due to a weak glute max. Then you have short external rotators in the hip, these four external rotators, very likely piriformis is the primary one that would cause like an SI joint pain. Then you have because they're external rotate, they're stabilizers. They're also horizontal abductors, but they're antagonists as rotators of the hip would be the TFL and the gluteus minimus, which can internally rotate the hip. So you've got the external rotators, the piriformis, the gemellus, the obturator internus, that are external rotators, including, and you could count the quadratus femoris, but those are external rotators that are in the glute area, and then you've got they're fighting against a tight TFL and gluteus minimus, which are doing internal rotation. And gluteus minimus and the TFL, I've mentioned it before, they work together. They should be treated together because they function together. The gluteus minimus is like the little sibling of the TFL, and they even share fibers on many people. So the gluteus minimus, sometimes if you're treating the motor point of the gluteus minimus, you will see the TFL firing, you might see the rectus femoris or the vastus lateralis firing, because on some percentage of the human population, they share fibers with together. So we give them all separate names, but they're on many of us there's overlap of these muscles. So gluteus minimus and the TFL should almost always be treated together, as if there's a dysfunction and you're trying to help either hip abduction or hip internal rotation, then I would treat them together. Um, so when the TFL is tight and then the gluteus minimus is tight, because they work together, they're putting internal rotation on the hip. And so what is going to keep your toe from turning in while you're trying to walk? The external rotators in the hip, so piriformis, those gemellus and obturator internus to some degree, quadratus femoris, all of those can correct for a bit of an internal torque on the hip. And that's going to keep you walking normally. But they're fighting each other. And then, I'm not going to get into hip issues, but a lot of times pain over the greater trochanter is this battle of the external and internal rotators. And that's how I would always address pain over the greater trochanter. But, back to how does the TFL cause low back pain? It could be putting strain on the piriformis, which is then causing pain at the piriformis attachment to the sacrum right by the SI joint. So a lot of times people are rubbing right there in that SI joint area with pain. And of course, that pain at the SI joint can be from the spinal erectors, the spinal erector aponeurosis, but very often it's from a short, tight piriformis that's loaded with trigger points, tight bands. So it's gotten so short and so tight that just standing will cause pain at the SI joint for people. Um, so I think I covered everything that I wanted to cover for the TFL, but this is how the TFL can cause low back pain. And it should be considered in those three different variations for causes for low back pain. And when we think about the way the body works and we understand the actions of the muscles, how they interact with their antagonists. What are their antagonists? And I didn't mention adductors, but tight TFL can definitely cause problems with adductors as well. That's less likely to be a low back pain issue, but understanding the antagonists of the TFL for all sorts of hip dysfunction is very important. And even, maybe you could even make an argument like from the lower cross syndrome perspective. TFL is tight, overworking, and now weak because a tight muscle is weak, right? Short, tight muscle is weaker. What if somebody has a tight TFL and they have to do a lot of I don't know, say stair climbing. Maybe they're a cyclist, maybe they like to do stationary bike or something like that. Maybe, especially as a cyclist, because you're bending forward, maybe they're getting overuse of the psoas. Maybe the psoas is starting to get shorter and tighter due to tension in the TFL that's already short and tight. Now you're getting that low back pain from a tight psoas that's secondary to a tight TFL. The TFL got tight first. Now the psoas has to work harder. Now the psoas is getting short and tight. Now it's pulling on the front of the lumbar vertebrae, causing low back pain around that L4, L5 because of that the psoas pulling so strongly and creating more lordosis in the low back than is normal. So you have low back pain from a tight psoas that started with tension in the TFL. So that's my thought experiment for today. I just like to sort of put that in your head, like plant a seed. Think about, pick a muscle that you know causes a joint dysfunction, like low back pain, shoulder pain, neck pain, and think about all the ways that dysfunction in that muscle could lead to the chief complaint that you're looking at. And really, I feel like those thought experiments um, will not only help you to help others when they ask something in a group, and maybe the people that they were counting on threw it right back at them and said, "Go back and muscle test more." Um, Maybe you can help them with this patient, especially if they don't have a lot of background in orthopedics. You may be able to help them if you have thought through the different ways that a short, tight muscle could cause dysfunction that leads to that problem. At the end of the day, that person may be in some small town. They may be the only hope for this patient. And I really hate to throw back at them that they first need to go do some online webinars or something to, to up their assessment skills before I'm going to help them. I would prefer to think of the scenarios where what they're explaining could be happening and give them some options based on that for what they could look at next. Because when I see this sort of pain that they've described, these are the multiple ways that this could happen to that person. And based on what they've told me, what they've missed is likely X, Y, and Z, or just X. And go check this on the patient and see if this is what they need. Because at the end of the day, it's all about helping the patient. And for me, it's also about helping the practitioner to help the patient at whatever level they're at. And I don't want to throw back at them that they need to go learn more before I'm going to help them. And there's certainly no risk in them putting one extra needle in the muscle that I'm telling them to try and try that. There's definitely no harm as long as the patient, I mean, as long as the practitioner is doing safe things. That what's the problem? A 2 cent needle in this one muscle that I'm suggesting. And I'm not going to be embarrassed to have suggested it, in spite of everybody else writing tomes about how they need to test for all of the lumbar restrictions, or did you do this, or did they get an EMG, or is the patient taking enough magnesium, blah blah blah, blah. When you've done the thought experiments about how these problems could happen, then I think, just better equipped for your tough patients. You're better equipped to help others when they get stumped, because you've thought about how the body moves and the different ways that these dysfunctions can occur. And I just think it makes us a better practitioner for those people who are too old, too obese, whatever it is, they're in too much excruciating pain to be able to run them through a series of muscle tests before you even have an idea of what you should be doing. When you've thought about how the body works and how it can dysfunction, how they could end up with this pain that they've described, and then you've interrogated them on so that you get a clear picture of where it hurts, when it hurts, why it hurts, and then you know where to go with your treatment. And really, when you're treating people in their 60s, 70s, 80s, everything's going to test weak, and it's not necessarily the main problem. Um, and I don't know about you. I had a patient, he could barely pull himself far enough up to get his face into the face cradle because he's 82 years old and he has low back pain, and he's overweight, and there's only so much I'm willing to do to move the patient because I don't want to hurt them. I don't want to push on anything. I don't want to pull on anything. So I just have to wait for them to take a full minute to kind of crawl or pull themselves forward to get into the face cradle before I can help them. This is not somebody I can put through a lot of muscle tests. It's just not going to happen. I have to ask them, where does it hurt? When does it hurt? And go from there. And really, for this guy, it was low back pain. And by the way, yes, my treatments have been greatly helpful for him, in spite of him being told to just expect to be in pain at his age with spinal stenosis. And he responds very well to electric stimulation acupuncture on motor points and the treatment of trigger points. But I've been able to help him because I know, based on his symptoms, where to look for the problems. So, okay, sorry I ran kind of long. Um, I will blame having jet lag, but I hope that that was of some relevance and use to somebody out there, and I hope it is encouraging to people who maybe have been working in orthopedic acupuncture for enough time, 2 years, 3 years, that it's time to expand your grasp and understanding of how the body reacts to pain. What are the dysfunctions possible? What are the actions of the muscles? What are the antagonists of those muscles? What are the synergists of those muscles? What are the postural patterns that are leading to dysfunction? And with that, I will close, and I will hopefully talk to you next week. Take care.